Assalamu alaikum wa rahmatullah. Welcome everybody. Welcome in Saudi German Hospital. Now we will start our webinar, Esthetic Orthodontics by Dr. Mohammed Al-Bawardi, the consultant in orthodontics and the head of department in Saudi German Hospital, Dental Department of Saudi German Hospital. Start, Dr. Mohammed, تفضل.
Hello, everyone. A pleasure to be here with you guys today talking about aesthetic choices of orthodontics. So basically, the aim of this lecture hopefully is to deliver a message talking about how can we achieve a good aesthetic results using aesthetic choices of orthodontics. Right, so let's go briefly. What is the indication for orthodontics? Why would people go for braces? I presume like majority of the audience who they are from non-dental background, so I'll try to use a very basic terminologies. The indications for orthodontics, why would people go for orthodontics? It's basically crooked teeth, crowding, spacing, or aesthetic smile line, and also for some psychological reasons, and to improve the mastications. Let's talk about this case, for example. This patient presented to us with severe upper-lower crowding. She was a young girl. She barely smiled because of the shape and aesthetic of the teeth. She had really psychological issues. We treated her with upper-lower fixed appliances using metal brackets. We achieved a good results, which honestly changed her life. The choice of treatment was the metal brackets, which we're gonna talk about briefly. What is the difference between metal brackets, clear aligners, lingual orthodontics? That's another case. Adult patient presented with severe upper-lower crowding, bilateral crossbite. He wasn't satisfied with the results. There is a very poor oral hygiene. We can see that after about 2 years of treatment, we achieved reasonable results. He's not finished yet, but the results are quite reasonable. Now he can smile normally. This case, for example, when he started, he used to have upper-lower metal brackets, fixed appliances for almost 9 years without any improvement. When he came to us in the clinic, we explained to him that the problem wasn't the teeth, it's jaws. He has what we call it class 2 malocclusion. We can see that he's showing severe gingival show on smiling and severely retrognathic mandible. So the treatment was upper-lower fixed appliances. With the help of the surgeon, we managed to achieve a reasonable results. Actually, it's excellent results. The patient was extremely satisfied with the results. So we managed to achieve a good result using the metal brackets. Okay, so let's go briefly. Let's talk history. When the whole story started, actually back more than 50,000 years ago, people started to notice that the crowding started about that time. Before that, which is interesting, there wasn't much of crowding. Then after that, ancient Egyptians, they started to invent how they were going to fix the teeth. They found some, as we can see from the photos over here, wiring the teeth, trying to move them. And that's more than 5,000 years ago. And in the 17th century, a French dentist, his name was Pierre Fouchard, started to invent what we call it primitive way of moving the teeth. And going to the father of orthodontics, Edward Angle, he invented the conventional fixed metal brackets, which wasn't pleasant in terms of shape because it used to be like a full band, cover the whole teeth. That's the one on the left here. But it's used to move the teeth. And in the late 20th century, a lot of inventions came through trying to improve the choices of orthodontics, because not many people really prefer to go for metal brackets. So we started to see small metal brackets, ceramic brackets, polycarbonate brackets, as you can see here in the photos. At that time, that was a great option. Rather than going for metal brackets, you can have another choice of aesthetic choices of brackets. In the 21st century, we started to see a lot of improvement, especially seeing the artificial intelligence intervening and digital scanning, 3D printing. Those altogether helped a lot to develop innovative techniques and mechanics in orthodontics. So let's start talking about aesthetic choices in orthodontics, starting with the ceramic brackets, for example. What is the advantages for ceramic brackets? It's better aesthetic compared to the metal. The wire itself can be colored, like white coated color. It can be fixed, so the patient will not have the choice to remove them, take them off and on, and it can manage all the cases. What about the disadvantages? It is less aesthetic compared to aligners and lingual orthodontics. It can lead to erosion, enamel erosion, and it's tricky to remove them off from the teeth, and a little bit high costly compared to the metal brackets. Okay, let's go and talk about what about the latest technologies in orthodontics. Recently, in the last 10 years, we can see a lot of competition comparing the clear aligners and the most popular companies, Invisalign, and lingual orthodontics, which is called Incognito. They are competing, each one of them having their own advantage and disadvantage. So let's start with Incognito, which is the lingual, which is hidden behind the teeth. It's completely customized appliance, which can be scanned digitally or through the impressions, the mold. It's completely invisible. So once the patient is going to have them on, nobody will going to see it. It's fixed. So I will not rely on the compliance of the patient. Ideal for someone who's extremely busy, so who doesn't have the time to take them off and on. Ideal for the busy professional as well. What is the disadvantage? It's a little bit costly because it's an alloy that has a lot of gold inside it. Why the gold? Because it will gonna stand the occlusal forces. Some patient in the first week, they might have some kind of discomfort, especially when they eat. Not all of them, they will gonna prefer to have them. Time consuming, because the installation of the device itself sometimes takes about an hour. So we need to be really careful when it comes to the case selection. Right, that's an example, one of our patient, how we will gonna place the modules. And as you can see, it's completely hidden, so you don't see much. Right, and that's another photo. And you can see it's gold hidden behind the teeth, beautiful. Going to the next one, which is the aligners, starting with Invisalign. Honestly, aligners are my favorite appliance, and I will explain to you why. We're gonna have different brands, but I'm gonna focus more on Invisalign, which is basically has a lot of research and a lot of data on the literature. Invisalign itself, it's clear aligner. Those are typical examples. Metal brackets, which is commonly used, and the Invisalign. you can see there is a huge difference when it comes to the aesthetic. So basically, we can deliver a very aesthetic results using an aesthetic choice. Before, we used to deliver aesthetic results using the metal brackets, which wasn't really favorable for many patients. Now we have the advantage of delivering an aesthetic choice using aesthetic appliances. We can see that that's the attachment in the Invisalign itself, which is a point of force, which we're going to cover later on. Okay, so let's talk about the advantage for the aligners. It's customized, it can be scanned, it's invisible, removable. So some of the patient, they prefer to have a removable choice. The reason why they can take it out during eating, eat normally, then put it back again. Ideal for professional people. The price are quite reasonable when it comes to the incognito, which is the lingual, because obviously it doesn't have gold. The disadvantage can be costly compared to the metal brackets. I will completely rely on compliance because it's removable. So if the patient do not wear them, unfortunately, will not be able to get a good results. And it's limited to certain cases. So it will not fit all the cases at all. Okay, so we're talking about here how innovation starts and how the market will gonna shift us actually, and technology are doing a lot these days. These days we can basically take a scan for the patient. There is no need to take a mold at all and do the digital treatment planning, which we call it a clean check. Then we agree with the lab technician to print the aligners, and we're gonna have few examples. There are different scanners in the market. Some are good, some are not good. At the end, they all do the same purpose, which is taking a 3D printing or scanning for the teeth, and we're gonna be able later on to apply it on the system to print it. That's talking about the Invisalign itself, how it improved, how it's evolved during the years. In the market, there are different aligner brands. Some are quite new, some are targeting the end user. So they bypass the dentist or the orthodontist. And that's becoming like a big legal issue in Europe and US. But we're going to focus more on the most popular one of them, which is Invisalign, as there are a lot of literature and information about it. And that's talking about the number of patients, jumped a lot in the last few years. It used to be hundreds of thousands and it ended up millions of patients. There is a lot of improvement on the system itself. It used to be limited for certain cases. Now it did improve a lot, and it can manage plenty of cases, which we're going to show you some cases later on. Right, the system itself evolved through generations. There used to be a lot of difficulties. Nowadays, it's excellent. It's doing like a lot of movement, like rotation, deep bite, anterior open bite, and it's been supported by the literature. Can we correct class 2s, class 3s? Yes, it can correct, and you still can use elastics, which is the rubber band elastics. Let me share with you one of the cases. He's an orthodontist to be, inshallah. He's my colleague. He went everywhere, and everyone said that you're gonna have to do orthodontic surgery. I'll show you his clean check. That's a treatment plan. Actually, I just saw him a few days ago, and mashallah, he's doing fantastic. Almost we're matching the clean check. He's almost there. That's the clean check. That's the treatment plan. That's where we spend a lot of time planning the case. So in this case, he had severe anterior open bite, and we plan to close it without the need of surgery, without the need of extraction, only by using IPR, which is interproximal reduction, and elastics, rubber band elastics. Okay, that's another case where our patient used to have severe constricted maxilla. We expand the upper and lower, and it showed an excellent results. Right, that's case number 3. Our patient here started with severe bimax crossbite, anterior open, proclined upper lower incisor, and severe crowding. We managed to treat this case without extraction, just by expansion, a lot of elastics, I have to say, IPR. That's this case, for example, if we're going to treat it using metal brackets, we'll have to extract some teeth out, but we managed to treat the case without extraction. That's the simulation, that's the treatment plan. We can see that the bilateral, severe bilateral crossbite, it took about one year and 8 to 9 months of treatment. That's the other view. We can see amount of constricted maxilla. We managed to expand the maxilla without the need of any surgical intervention, only Invisalign. Right, that's the same case. We can see that's before, that's after. We can see the blocked out lateral over here, bilateral, crossbite. Look at the amount of expansion. That's a very reasonable results. Look at the side over here, lateral, complete, lingually displaced, bilateral, crossbite, narrow, maxilla, severe upper lower crowding, managed without the need of extraction. That's the amount of expansion that have been done using the Invisalign. Right, that's another case where we basically managed to treat an anterior open bite, proclined upper lower incisors without the need of extraction. Yeah, so we can see over here the amount of proclination. The proclination is the angle of the incisors forward. We can see it up and lower, and the amount of crowding. Managed to treat the case without the need of extraction. Just slight IPR upper and lower, and retraction and retroclination of the incisor. Right. So the evidence showed that aligners, specifically Invisalign, can have shorter time of treatment, can manage the vertical anterior open bite, deep bite. Some of the cases can treat class 3, class 2, and there are a lot of improvement on the system itself. But I have to say, there are some cases that can be very challenging for the aligner, such as severe rotations, impacted canine, surgical cases that still will need some intervention with metal brackets. Sometimes we can combine metal brackets with aligner itself. Okay, that's basically talking about the delivery workflow, where it's basically everything is so digital. You just need to take a scan, then send it abroad through, which is basically going to be everything online. Then you're going to check the clean check, which is the treatment plan. Once you approve it, it will going to be sent back to us where we place the aligners. That's basically talking about the same thing, where nowadays there are different approach. For example, now there are few application that through a mobile application where the patient can take photos for their teeth and can give them a simulation, like an initial one, where they need to go after that for proper consultation. where they do the scanning and they finalize the treatment plan. Okay, so that's talking about the advantage and development of the Invisalign itself. And here talking about the improvement of the Invisalign and the attachments being added. And that's something to do with mechanics, how we're gonna move the teeth and how we're gonna improve the inclination and angulation of the teeth. Recently, there is an extra advantage that's been added to the Invisalign itself, which is basically what we call it mandibular advancement feature. That is very important feature. The reason why, because here in Saudi, we have a lot of class 2s, whereas basically the mandible is backward, which is, we call it retrognathic. It's really important for us to raise the level of awareness for the patient, tell them to go to the dentist, to the orthodontist, because we can improve the growth, we can avoid surgeries. So always we tell the patients, we tell the parents, please, if you in doubt that the kids, they have retrognathic mandible or retrognathic maxilla between the age of 8 to 12, please visit the orthodontist. So we can modify the growth, and I'll show you a case. So what's happening now with the mandibular advancement, they are trying to copy what we call it a functional appliance, or commonly it's called twin block functional appliance, which is a device that will gonna help to improve the growth of the mandible and therefore avoid the surgery in the future. That's an example. Look at the amount in the top photo here. When she came to the clinic, she was 12 years old patient. She has severe retrognathic mandible. We can see the lower lip position, labiomental fold, and the amount of vertical dimension, which is this part, it's a bit short. It's all because the mandible is retrognathic. So what we did over here, we gave her growth modification. It's a device. It will gonna force the mandible to go forward, and it will gonna improve the growth. It has to be for growing patient only. So we always ask the parents, please, if you have a doubt, just go to the orthodontist. And we can see a huge improvement. If we didn't do anything for her at that age, we're gonna just tell her that if she, for example, if she passed that growth time, we're gonna tell the patient you have to come at the age of 18, 19, and we're gonna do only surgical correction, surgery. Okay, of course, any orthodontic appliance, any device will have to have some kind of retainers, and retainers come in different shapes. Commonly, we used fixed retainer, which is a bonded wire, in addition to removable retainers. Hopefully, we have covered like a few interesting points. I would like to thank you all.
Thank you, Dr. Mohammed.
I'm happy for questions.
Yeah, we start by question now. Anyone have a question? Could you please, any participant has any question, write in the question? Oh, there is one question asked before Dr. Mohammed by Dr. Waida, I think. What is the best age for treating overcrowding of teeth?
Okay, that's a very...
By Dr. Waida, she's asked.
Yeah, that's a very good question. We always recommend the patient to visit the orthodontist and the dentist at the age of 7. That's the best time where the permanent teeth start to erupt. Sometimes at the age of 7, we can intervene if there is any skeletal discrepancy. For example, if the top jaw are slightly behind of the lower jaw, we can tell the patient that that's the appropriate time that we can correct the skeletal discrepancy. We correct the bone, not the teeth. That's why it's really important that we recommend to visit the orthodontist at the age of 7. For example, if there is no problems at all with the bones, we just keep following the patient 1 visit per year until the age of 12, which is most likely most of the permanent teeth will gonna erupt. At that time, we're gonna go for the conventional, which is either metal brackets, Invisalign, Incognito, whatever choice. All those options are available. And now we are having the pleasure of offering like different devices for the patient. So patient will gonna go for metal brackets, that's an option. Invisalign, that's another option. Incognito, that's a third option. And hopefully that's answering the question. Any more questions?
Dr. Mohammed, there is another question related to this. What is the best time for the treating of impacted canine also?
Okay, that's another good question. Impacted canine, usually we're going to be erupted at the age of 12, but we have to palpate the canine at the age of 10. For example, at the age of 10, once we palpate the canine and we are having a doubt, we'll have to take an OPG to evaluate the position of the canines. If the position of the canine are quite poor, we're going to have to intervene by different approaches. For example, we can extract primary teeth and apply headgear that will going to increase the chance of moving the canine down. If there is no problems at all, we just need to wait until the age of 12. But it's really important to take an examination and x-rays at the age of 10 to avoid any risk of root resorption of the laterals.
Another question, Dr. Mohammed. How much stable expansion possible in lower arch with Invisalign?
That's a very good question. Okay, so sometimes we evaluate each case separately. In the lower, we, as an orthodontist, we don't like to call it expansion because we know that the evidence suggested that expansion in the lower, we're going to have a high relapse chances. So if the lower has a buccally or lingually tipped crowns, that's a very good indication for uprighting the molars. But if the lower are constricted due to a bone, that will sometimes we're going to have to accept and just upright the molars and premolars and plan for long-term retention. In the upper, it's different. It depends. For example, the case that I showed that has severely bilateral crossbite, we ask the patient to wear the Holy retainer for quite a long time. I ask the patient to wear it for good 1 year full time, followed by 12 hours extra year. Then he will gonna have to keep wearing it only weekends, so certain days of the year, just to make sure that we're gonna maintain it for quite a long time. So it depends if I'm gonna expand and correct the skeletal or dental.
Okay. Another question, Dr. Mohammed. Question: if upper teeth front is coming out, in which age should see the doctor?
In which?
In which age?
Which
should
age?
see the doctor? Yeah.
Okay. There is no age for orthodontics. Let's say, because I always get this question, what is the optimal age or what is the best age to start ortho? We always say that 12 to 14 is the time that we can start treating the patients, because all permanent teeth are going to start to erupt. But sometimes we ask the patient to come early at the age of 7 to correct any skeletal discrepancy. So let's call it as a rule that at the age of the 7, you must visit an orthodontist. So you must take your kids, your relatives to the orthodontist at the age of the 7. Then the orthodontist will instruct you to follow up yearly appointments, just once in a year, just to make sure everything is fine. And you can start the treatment at the age of 12 to 14. But sometimes you can start early at the age of 11, for example, because it depends on the case. And is there any restrictions when it comes to the age? No. So can we treat a patient who's 60? Yes, we can. I have a patient, she's 79 years old patient. The gum condition is excellent. When she started, the root condition was excellent. So she had ortho. So there is no indication. We always assess each case separately. We always need to make sure that the gum, the root resorption are extremely in a good condition.
Okay, another question by Dr. Mohammed. What is the indication and the contraindication using fixed and removable retainers?
Okay, so it depends on the case. It depends on the malocclusion itself. For example, if you have severe rotation, severe crowding on the lower incisor, I would highly recommend going for a bonded wire or fixed retainer. Generally speaking, I always love to mix having a bonded wire in addition to removable retainer. If I'm going to expand the upper, for example, with severe crowding or severe rotation, I would definitely mix between bonded wire and removable retainer. The choices of retainers always depends on the starting malocclusion. If you have, for example, spacing, midline diastema, the evidence showed that there is a high relapse chances. So you always need to plan it from day one. That's why sometimes it's really tricky once you're going to have a transferred case, because you always ask the patient to bring their initial records so you can plan their retention.
Okay, and what is the best time to put the retainer? Should be immediately after the orthodontic treatment? What's your opinion, Dr. Mohammed, in this?
I would highly recommend after the debonding right away.
Yeah, so it should be immediately.
Immediately, yes.
Good. Okay. Another question: what is the best treatment for lower third molar impacted teeth, lower front teeth overcrowding?
Okay. So the evidence shows that the lower wisdom teeth has nothing to do with the crowding. I remember when I joined the dental school almost like 20 something years ago, we used to say that third molars are the reason for the lower incisor crowding. But recent studies showed that it's nothing to do with the third molar at all. So the new recommendation, for example, NICE guidelines, UK recommendations, which is applied in UK and Europe, they recommend if the third molars has no problems, no pain, no complications, nothing at all, just keep them, leave them, do nothing, just observe. Take an X-ray once in each 2 years. The reason why we have lower incisor crowding, that's condition called late lower incisor crowding. That's something to do with age, because they did a lot of studies where they took the third molars out and still patient, they have lower incisor crowding. So it's nothing to do with the third molars. So the recommendation, which is based on science, recommended to do nothing and observe, unless certain conditions such as pain, discomfort, caries, badly broken, yes, at that time we can remove them.
Question by Dr. Roy: can the finishing with Invisalign would be the same as with the conventional brackets, especially in extraction cases?
That's a very good question. Invisalign itself has a limitation. So once we plan the case for extraction cases, for example, we need always to plan for that limitation. For example, I always plan my case with Invisalign that I'm gonna plan certain movement, let's say 130%, because I know Invisalign are gonna give me only 100 or 90%. For extraction cases with Invisalign, I always go for refinement, which is another course of treatment. Let's say if I'm gonna go for 35 aligners, that's the first course of treatment. I always, for extraction, I'm gonna go for another course for refinement. And it always gives like a nice results.
How much estimated cost minimum for correction of organized teeth, and what is the ideal age for this treatment?
Sorry, could you repeat that question?
Yeah, how much estimated cost for correction or organized teeth, and what is the ideal age for this treatment? This question by Dr. Muhammad Yunus.
So sorry, if you
how much is the estimated cost, the minimum cost for orthodontic treatment for anyone?
Invisalign or metal?
I think it doesn't matter, but for the two.
Okay, so the cost can be varies from place to another, institution to another, and incognito, for example, which is the lingual, can be considered the highest cost because it has a gold alloy, so it's considered the highest. Invisalign comes next. Metal brackets can be classified as third. But the price varies. It depends on the case itself, the malocclusion, the amount of teeth movement, the amount of time. So it varies. You cannot just give like a category for the cost.
Okay, we will take the last question for this webinar. How stable are the results of mandibular advancement with Invisalign?
Okay, that's a very good question actually, because the mandibular advancement, they started to have the device itself only 2 years ago. We are actually conducting like a study currently, trying to evaluate this. I have few cases. It showed like a nice results dentally, but we are trying to evaluate the skeletal changes and compare it to the twin block, which is the modified, which is the most popular mandibular advancement. As far as I can see from my little experience, yes, it is improving the skeletal discrepancy. But is the changes are purely dental or skeletal? It's questionable. The device is quite new, and we are waiting for the literature to give us more feedback.
Good. Thank you, Dr. Mohammed, for this nice presentation, and thank you for answering all the questions. And thank you for all participants today. And thank you so much.
Thanks a lot, Dr. Mohammed Al-Bawardi, for that interesting talk. Thank you so much, Dr. Mohammed Abu Saud. Thank you, everyone, for joining us for today's webinar. See you next Saturday at the same time. Assalamu alaikum wa rahmatullahi wa barakatuh.